Welcome, everyone. We are excited to have you share some of your time today as we move through the next session of our Rural Nursing Innovation Series. I would like to introduce our next presenter coming to us today from the University of North Carolina, Greensboro. Please join me in welcoming Tammy Hall as she shares her research on the silent voice of rural maternal health.
Hey, everybody. It is so good to be with you today. I am Tammy Hall, and I am from the University of North Carolina in Greensboro. And I just wanted to share with you the research that I've been doing on rural health and where it pertains to our maternity patients. Oh, I'm so sorry. I'm all the way at the end. So here are some objectives to define rural health and then understand the landscape of rural health where it pertains to our maternity patients, exploring the challenges of our rural maternal population, and then looking at shared decision making. This has been my focus in research on how we can incorporate shared decision making, and then explore the opportunities for our research and practice. So here's the foundation of what got me started in this research, and that is this. In the last several years in the United States, our maternal mortality has increased year over year until we got to 22. But if you'll look at the rates, even in 2022, we are still not below our pre-COVID maternal mortality rate. And that has really become a problem for us. So we're looking at disparities. How can we address maternal morbidity and mortality, and looking at the populations that are most susceptible to maternal morbidity and mortality. And I just threw some statistics over to the side for you to look at, in which, to me, the 40 plus is really interesting that we I would not be having a baby at this point, but those over 40 are those numbers are 6 times greater than those who are under 25. So I just thought that was super interesting. So I just wanted to share about North Carolina. We are on the Atlantic seaboard. We are bordered on the east by the Atlantic Ocean. And then we have mountains in the west. And you may have heard about our natural disaster that we have just experienced in Western North Carolina, where many towns were completely obliterated because of flooding from Hurricane Helene. So that is impacting our rural population greatly. So this makes this even more challenging and important to address. Oh my goodness, I don't know why that's happening. I'm so sorry. So North Carolina is 5 times smaller than Texas, but we are second only to Texas in our rural population. So we are a very rural state. And we are defining rurality in North Carolina as a county that has a population of 250 individuals per square mile or less. So we have a very rural population and many rural counties. So here's the landscape of rurality in North Carolina and when it pertains to maternal health and birthing people. 13.4% of birthing people have no hospital within 30 minutes of them. 3.3% of our babies are born to families in rural counties, but only 1.5% of our providers provide care in rural counties. So our patients are having to travel to the more urban counties to get their care. The county with the highest Travel time is 58.4 minutes, so almost an hour to get to the closest hospital. And the average time in the state is 17.6 minutes. But the crux of this is this: our rural patients are at 9%, nearly 10% greater risk of experiencing maternal morbidity and mortality. And so this is a population where the percentages seem somewhat small. They are at such high risk for experiencing morbidity and mortality. So this needs to be addressed. Maternity care deserts are counties that have access to no obstetrician, family practitioner that provides obstetric care, a clinic, or a certified nurse midwife. And 3% of our babies in 22 were born into maternity care deserts. So the birthing mom had to travel to an urban center to deliver. So here are the 100 counties of North Carolina. And in the key, the beige counties have full access to a birthing center. Green would be moderate access, and then low access and maternity care deserts are blue and orange. And if you'll look, it's our eastern and westernmost counties that have the most maternity care deserts. And then our southern counties, many of our southern counties have low access. Low access means that there are less than 2 birthing centers or areas for our patients to deliver. That I believe it is 8% of the patients have no insurance. That are birthing moms or are women between 18 and 64. And there are fewer than 5 providers providing care per 10,000 patients. We have several socioeconomic barriers and cultural barriers in our rural counties in North Carolina. 17%, so nearly 20% of our patients live in poverty or our population. Unemployment is higher in the rural areas than it is in the urban areas. Medicaid, which is the public insurance of the United States, covers greater than 50% of the births in our rural counties. 1 in 8 of our birthing women are uninsured. The nutrition services enrollment is higher in our rural counties than in our urban counties. And housing, the crisis in housing has become very great in our rural counties of North Carolina because during COVID, so many people wanted to move from the urban centers into rural areas because they were able to work remotely. So people are being priced out of their communities. So people who have grown up in rural counties and rural towns aren't able to afford housing in their own town because people from outside are coming in and buying up the real estate and making the prices, they're driving the prices higher, so they can't afford to own a house. And then public transportation in our rural counties is a challenge. So in the research, it's been revealed that the social determinants of health that we study are the ones most closely associated with poor maternity care are insurance status, adequate housing, transportation, and food insecurity. This is the racial breakdown of our rural population in North Carolina. Various counties differ, but this is the entire state. So 69% of our rural residents are white, followed by 18% being Black or African American, and then Hispanic is next, and then multiracial, Native American and Asian wrap up the last 6%. And it's interesting to note that we have counties in the western part of North Carolina that are Cherokee and are autonomous and run their own health care. And so it's a really neat area to visit and learn from them about rural care. Intersectionality has become a big word in rural care because rurality itself is a disparity. But when you begin to intersect that with the other social determinants of health, maybe poor housing, race and ethnicity, transportation, housing, all of those, when you intersect that with rurality, it just compounds and compounds the disparities that these patients experience. So here's just an illustration, rurality at the center. When you look at the lack of insurance or that patient's income, do they live in poverty? When you intersect that with rurality, their disparities are compounded and health outcomes become worse the more you compound through intersectionality. So what can we do to improve maternity patient care? I posit that shared decision-making is such a wonderful way that we can start to include our rural patients and make them realize that they have a voice and a choice when it comes to their care. Shared decision-making is relational. It includes discussions that revolve around information sharing by the provider and the patient, understanding between the two, and the two understanding what their preferences are, because each is going to have their own set of preferences. What is the patient's priority? What history are they coming into this relationship with? And what do they need the provider to understand about them so they can enjoy a dialogue with the provider rather than a prescriptive plan of care that doesn't take into consideration what the patient's history was, what their culture is, what their preferences are, what their priorities are. And so shared decision-making brings that patient in and gives them a voice with their provider. This is preventing distrust, which keeps many of our rural patients from attending prenatal care or postpartum care, and increases their satisfaction and engagement. And what has come out in research is that those who have experienced shared decision-making are much more likely to travel to come to prenatal visits or postpartum visits because they have a relationship with their provider rather than just showing up and being treated like the next patient on the list and sent home. So our outcomes are improving because we are introducing shared decision making. How can we do that? Telehealth is a wonderful way that we can start moving toward shared decision making and keep it incorporated through postpartum and prenatal care. And then these other things that are listed, you can do that through telehealth. So telehealth would be a great answer to incorporating shared decision making with our patients. The travel time is greatly reduced. It increases those geographic disparities. So people who are living in Western North Carolina right now who can't get to an urban center could still have a visit with a provider. It doesn't have to be a physician that does telehealth. Nurses, we educate. That's our platform, and we would have such a great. We do have such great interaction with patients through telehealth. It's supporting equitable care, the provider shortage, that where we said that only 1.5% of our providers are in rural counties, that mitigates that shortage because those people in the urban centers can reach those out in the rural counties. It improves continuity of care so that same provider can speak with the patient from visit to visit and develop relationship. And then it helps us to reduce our severe morbidity and mortality. But we have disadvantages because In North Carolina, over 10% of our rural residents still do not have access to the internet. During COVID, we had rural patients who had to go park in the grocery store parking lot and share their internet with them so that they could complete their nursing assignments. So it is still a challenge to get internet access way out in our rural counties. What are our implications for as nurses? Incorporating mobile health is so important to take the care to the patient instead of having the patient have to drive so long to get to care because they don't have transportation. We have a rural health unit, a mobile health unit at UNC Greensboro that goes to the counties and takes care of patients, utilizing telehealth again, and us as nurses utilizing telehealth to reach out to those patients. Advocating for maternity services in the rural counties should be such a high priority for us. Getting our legislators involved and creating policy about maternity care so we can decrease our maternal morbidity and mortality. Teaching our providers about shared decision making and getting them on board. We do meet those relational providers that want to become involved with their patients, and to use those providers as examples for others to bring their patients along and show those patients that they do have choice. They do have a preference, and they can share what their priorities are in their care. And then educating our patients. We as nurses, again, are educators. So if we can get out and speak to these patients about the importance of their prenatal care, their postpartum care to prevent the morbidity and mortality, should be a priority as well. And then our implications for research. Developing new care models is such an important priority for us as well, to make sure that our rural patients' needs are being met. And then going and finding what other variables are intersecting with rurality and keeping our morbidity and mortality rates up and our poor outcomes up in those counties. If we can discover what else is intersecting with rurality, we could solve a lot of their problems. Translating our data into policy again, and then getting our students involved. I was so excited to hear Erica and Dr. Crooks talk about getting the patients in the rural areas, and that once they start learning about care in rural areas, they catch the bug and they want to be involved in it. And so that was so wonderful. I was so thrilled to hear that conversation. So as a recap, rurality is complex. It's just not that they live in a rural county. It's that they have higher chronic rates of chronic illness. They have less access to care. So it's very complex, and our outcomes are worse in our rural counties for our maternal patients. 21% of our counties in North Carolina are maternity care deserts. And then intersectionality compounds our disparities related to rurality. So we can improve by incorporating shared decision making, advocating for our maternity patients, continuing to do research, and then disseminating that research, and then working with our legislators in developing policy to protect our maternity patients in rural counties. So I'm open for questions.
Thank you so much, Tammy. That was wonderful. We appreciate that you took your time today to join us and share your research. This would be the time. If you have any questions, so please feel free to add that to the chat or the Q&A. In the event that you do have a question that pops up after the fact, feel free to go ahead and just shoot us an email. I'm going to type it into the chat, but you can reach us at info@grnen.org. And we will make sure to push your conversation along to the appropriate party. As always, we thank you very much for including us on your calendar today taking the time out of your incredibly busy schedules to join us. Thank you to our presenters as well. We are so appreciative that you are willing to share your important research with our community. And we wish everyone a wonderful rest of your evening or your day, wherever you may be dialing in from. And thank you very much.